Welcome and thank you for coming to our webinar on healthcare accessibility models using spatial data. I am Grace Cooper, an IPUMS Senior Data Analyst on the U.S. Microdata team with a focus on U.S. geography. I'm also a PhD candidate in geography, looking at spatial accessibility to healthcare in low and middle income countries. So just to orient you, first, I'm going to define what healthcare accessibility is and talk about different methods used to measure it. Then we're going to pause for a short Q&A if there's any questions. And then after that, I'll talk about an improved model and give an example application. Couple logistics. So this webinar is being recorded and will be posted online. There are real-time closed captions being auto-generated, and you can turn those off or on by clicking the CC button in your Zoom controls. Please send any questions about the Zoom directly to the host, IPUMS, and use the Q&A tool to ask any questions. The recording and materials will be posted on the Spatial Analysis and Health Research blog, and the code that I'll be referring to is going to be provided, which is in Python and executable in RStudio through Porto. And we will also post the written Q&A document following the webinar. So jumping right in, what is healthcare accessibility? The dimensions of healthcare accessibility start with spatial access. So that is what you think about: distance or travel time, supply and demand of care. Another dimension is the availability of care. So this refers to the services and provider capacity, number of beds, number of doctors. The affordability of services, so whether or not people have insurance, what are the out-of-pocket costs, and then quality of care. So what are the provider types available? What is the patient experience at different clinics? So these 4 dimensions of healthcare accessibility all have an impact on whether or not people have high or low access to care. We're going to be talking mostly about the spatial component today. So how do we measure travel time for spatial accessibility analysis? One way is through straight line distance. So on the right, we have a buffer around a single healthcare facility with a 3-kilometer buffer. So that's one way we might think about travel as the crow flies, through a simple buffer. For this type of analysis, you don't need any extra data about the road network or the terrain. So it's a simple one to use in areas with low data quality. Road network distance. Now this looks at travel along roads. So that enables you to actually think about where people are going to be driving, but it requires complete road network data, including travel speeds. So what are the speed limits? How rough are the roads for driving on? So in this example, the service area is created from network analysis. And it assumes that travel is restricted to roads and people aren't walking on paths outside of that or anything. One of the issues with road network in this example, this is a network analysis in an area in a low-income country where there's not a complete road network data set that it was built on. So quite limiting as to how we can understand where people can travel. And then finally, a friction surface is another way we can look at how travel time is measured. So this allows you to look at how travel across the landscape. So travel cost varies based on roads, different types of terrain, barriers such as rivers and wetlands, and allows you to measure travel along roads and outside of them. So in the same area, this is a catchment area around a facility based on a friction surface. And as you can see, we've captured a lot more travel in and between roads. So other things to think about with spatial access: supply. So that's the availability of healthcare services, which can be measured as the number of facilities in an area, the number of providers, the number of beds, different ways to think about supply. There's also demand. So what is the population that needs those services? If you're in a highly densely populated area, the demand is high, and we need to think about whether that demand is equal to the supply available. Distance decay. So this is the tendency for use of services to decrease as distance increases. So people are more likely to visit facilities that are closer compared to ones that are farther away if they are equal in all other respects. There's preferences, so factors that influence which services people choose, such as the gender of the provider, facility type, whatever the cultural norms are in the region. And finally, we have other factors: quality of care, the cost, hours of operation. Some facilities are open 24/7, others are open only during business hours. And there's many other characteristics of services that researchers have looked at. So these are the existing frameworks for measuring accessibility. On the left, we have network-based access. So the data used for network-based methods often use census population counts, often aggregated to administrative units such as census tracts and blocks. And they use road networks to do network analysis, to measure travel time. And these are ideal because they allow you to consider not only travel time, but you can incorporate supply and demand, distance decay, and those other preferences that I just talked about. When we look on the right, however, cost distance-based frameworks are typically used with gridded data. So gridded population data sets, which I'll talk about, land cover, elevation, and these are often used within a least cost path analysis. So that uses a friction surface, which is also a gridded surface that you can examine from a cell to cell. How long does it take a person to walk, drive, bike from one cell to the next, is essentially what a least cost path analysis does. Ideal on a data side. However, a cost distance base only allows you to have to consider travel time for the most part. So we're missing some of those other important features. So when we compare the two frameworks, the network-based, typically using census population and road network data, those data are not often ideal in low and middle income countries. Gridded population data sets, however, which are globally and freely available at high resolutions, those are ideal data sets to use in low and middle income countries. And again, network analysis, due to that lack in complete road network data, is often not an ideal method to use in low and middle income countries, whereas least cost path analysis, you can do anywhere in the world and you're not limited by data. However, the network-based framework, allowing you to consider all the different aspects of spatial accessibility, is ideal. And we want to think about more than just travel time. So I've created an improved framework for measuring accessibility that uses the gridded population, land cover, and elevation data, and methods that are ideal for using those gridded data, so the least cost path analysis with a friction surface. But it's done it in a way that enables us to consider travel time as well as supply and demand, distance decay, those preferences, and any other things that might come up. So before jumping into that new framework, I'm going to introduce a few different types of accessibility models. So there are simple metrics models. On the left, we have simple distance. So the red crosses are facilities in this example, and the blue triangles are population centers. So on the left, using simple distance, the facility A in the bottom left appears to be closest. It's only 10 kilometers away. That's probably the most accessible facility. However, when we look to the right at network-based distance, so travel along road networks, we see that facility B is actually a shorter trip if you're limited to driving. And we don't necessarily know if there are other barriers between facility A and the population point. But when we can add new factors into the equation, we see that it's not as simple of a story. Gravity models take things a bit farther than those simple metrics. So they allow us to consider distance decay by applying weight for preference for facilities based on the distance they are from the population center. So in this example, that bottom left facility is applied a higher weight than the one to the upper right, even though that one to the upper right has that shorter network distance. And then there are two-step floating catchment area models. I'll just try and refer to those as two-step models for ease of talking. But these are a type of gravity model, and I will break down what they are. But essentially, they allow us to consider capacity and demand of services on top of the network distance, the distance decay. In this example, we see that now that we understand where other populations are besides the single one we're looking at in the bottom right, we see that the facility to the bottom left has a lower capacity of only 5 beds, but a high demand of, say, 50,000 people, because there's a lot of other small population centers surrounding it. Whereas the facility to the top right actually has a high capacity of 100 beds and a low demand of only 1,000 people living nearby. Given that information, we can glean that actually that upper right one might be more desirable to visit with lower wait times and a higher availability of care. So let's talk about this two-step model and how do we implement it. So as the name says, it's 2 steps. This is step 1. First, we calculate the provider to population ratio. So that uses capacity, which is the number of beds or providers, et cetera, in the facility. And then it considers the population, which is the number of people within the catchment area of that facility. So here's the formula for that. So all it is taking the capacity divided by the population. So this map is showing an example of how we might compute the first step of the 2-step model. So these gray circles are around facility points shown in red, which have their capacity shown. A larger dot is a higher capacity, so maybe more beds. And the gray circles are those catchment areas using just a simple buffer. So you can change whatever the catchment size you want, but for your analysis, you have to define it early on and say, I'm going to say that anyone within 60 kilometers of a facility has access to it. So this facility is expected to provide services to all people in that area, which are shown in black triangles. So if we sum up the population within that gray buffer area, that's the bottom of the formula, and then the capacity is the number that we have attached to the facility, we can calculate the PP ratio. So we were focused on the facility for the first calculation in step 1. Now we go to the population point and focus there. So for the step 2, we sum the PP ratios within the catchment area for the population point. And I'll expand on that with this map. So now we have the facility points are shown as black squares with their size, greater facility point size boxes indicate a higher PP ratio. And then the blue circles are population points, and greater size for those dots indicate a higher accessibility square. So this is actually showing those final accessibility squares using the two-step model. And as you can see, the ones that are the population points in areas with overlapping catchment areas for multiple facilities, those are larger, indicating they have higher accessibility. And that's because they have overlap from multiple facilities. And since we're summing the PP ratios from multiple facilities, they're getting a higher value. And so those people have higher accessibility according to the two-step model because they have access to two facilities in this example. So with this flexibility of the two-step, there are some data requirements. So it's beneficial because we can incorporate other factors into the analysis. And there's many more that I haven't even talked about. You can incorporate insurance coverage and how that influences the demand for care. You can talk about facility competition, transportation types. It allows you to incorporate multiple transportation types, assuming people are walking and then catching a bus, or driving and then walking, which is in line with reality, as well as distance decay. It is limited though, because it relies on high resolution census count data. So it requires small area geographic identifiers, such as census blocks in the US, and complete road network data. So if those smaller, lesser known roads are not included in the data set, you're not going to have a full picture of where people can walk. It also requires temporally recent population census. So in the US, we have the American Community Survey that comes out every year. So we have a pretty good understanding of population in every point in time. But if you're looking at low and middle income countries, oftentimes they only have a decennial census. So you might be working with, population counts that are 9 years old, and that's not very helpful for your analysis. And finally, the two-step is limited by the fact that it overestimates demand for care. So if you remember, some people in that previous map overlapped with multiple catchment areas. So when you're thinking about just the demand for care, those people are counted in both facility estimates. So in both of their catchment areas. So they're counted twice. So what is next? I'm going to introduce a new raster-based model that allows us to do the two-step model in spatial research in low-income countries where we have better data available in a raster-based format. All right, so now I'm going to introduce that improved model, which is a raster-based, that's how I'm referring to it, is a raster-based two-step model. So it uses that network-based framework in the two-step model with raster-based data that's commonly used in the other framework. So for instance, we're using gridded population data, for instance, WorldPop or Landscan, and then a friction surface rather than road network data. So first I want to define some terms. What are different types of data? So here I'm showing in the Kisii district of Kenya, a map of sub-county, these are sub-counties with the population aggregated to the sub-county and shown where higher populations are shown in darker blues. So this is vector data. It's polygons, and it essentially assumes that the population within that sub-county is the same throughout. It's dispersed evenly throughout that population or sub-county. And then the red dots are facilities, and the blue triangles, which are a little hard to see, are centroids of those sub-counties. So if the two-step, if we were to use this vector data, those black triangle centroids would be what we would use to simulate population locations. On the right, I'm showing for the same area, world pop gridded population. So this is raster data where it's grid cells, where each grid cell, the value it's showing, is showing you the population value. So deeper blues are more highly populated than the whites. So if you compare these two, it's painting a very different picture about where people live, and would actually be a much better indicator for the two-step for location accuracy of where populations are. So that's the difference between vector and raster data. So steps of the raster-based model, I'm going to start with step one, which is creating the cost raster or friction surface, same thing. So the purpose, build the friction surface representing the time it takes to travel on foot across a grid cell. So in total, it will have a minutes per cell value. This replaces network analysis in the typical two-step model, and it represents travel beyond roads. And this is what it looks like at the end. So I've mapped it to show walkability from easiest in dark green, so that's going to be along roads, to hardest in red, where those red spots are probably lakes and wetlands. So then there's several inputs that if you were to take the code that we're going to share, you would need to then download the following inputs for yourself, for your study area, and input them into the script. So starting with OpenStreetMap, which is a great resource for vector-based roads, rivers, a lot of different information that's actually crowdsourced. Anyone can add to OpenStreetMap, and then it's validated by researchers to be true. And then it creates a pretty comprehensive data set of where things like roads, rivers, and wetlands are. I say pretty comprehensive with a bit of an asterisk because it's still not perfect, which is why we want to do the friction surface to really gather more information about where people can live or travel. So you'll take those three parts of the OpenStreetMap data set and add some fields to it. So for roads, you'll need to add a travel speed value. If you're looking at walking, you need one value that indicates a high level, a low travel cost. So it's easy to travel on roads. Rivers will also need crossing cost values, indicating a high level of costs, right? It's very hard to cross a river, and wetlands are the same. And so that's what that data set might look like in vector format. Another input, we want to think about vegetation. So if we're looking outside of roads where people are walking, what types of vegetation are they crossing? So for my analysis, I used ESA World Cover. So you'll download that, and it's a raster-based data set or any other land cover for your study area. And you'll need to reclassify it to represent those travel speeds. So permanent water bodies, again, higher travel cost values. Versus bare earth is much easier to traverse. So you'll have a lower value there. And within the code provided, if you use it, there's more in there about how to reclassify things. So this is just a high level look at that. So this is what, for the same area, the land cover looks like. So you can see those permanent water bodies in blue, tree cover in green, shrub land in orange. So all of those different classes would be assigned a different value to indicate how hard or easy it is to cross them. Then we want to think about elevation. So I used the Shuttle Radar Topography Mission, which is a global elevation data set, SRTM. You'll download elevation data. Don't need to make any changes to it. And this is used to derive slope and apply Tobler's hiking function. So this tells us what the penalty is for traversing difficult terrain. And I'll talk more about that in a bit. This is what a elevation data set in that area looks like. So the first step of this first script, creating the cost raster, is converting those vector layers from OSM to raster. So here we have the rivers and wetlands, and then you can see they're converted into grid cells. Then we combine all raster inputs. So here we have roads, the rivers and wetlands, land cover, elevation. That's all stacked on top of each other. Some things are given more preference than others. For instance, rivers are, matter more than a road if it's, assuming it's cutting through that road that you cannot cross it, or it's at least highly difficult. And then you're given a base cost raster, which similar to what I showed before, green indicates easier walkability, red indicates harder. So then with that base cost raster, we're going to be combining it with slope. So now we need to calculate slope using the elevation data set in degrees. And this is a fairly simple step using ArcGIS Pro tools. So now we have a slope surface. And we can apply Tobler's hiking function, which basically is estimating the walking speed based on slope. Tobler found that the fastest walking terrain is at a slight downhill, but as you go steeper and steeper downhill, your walking speed slows down, similarly to how the steeper up you go, your walking speed slows down. So that's shown on this graph where we have walking speed increases as you go up on the y-axis, and 0 is near the middle. So the top of this red line at a walking speed of 6 is actually slightly left of 0. So that's slightly downhill as the highest walking speed. But as you go downhill, so the slope is on the x-axis, and as you go more and more negative, so that's a downhill increase, your walking speed decreases. And the same goes for when you go positive in the slope, your walking speed decreases the higher your slope is. So in this step in the script, it applies this function to the slope surface to understand what is the penalty we now will be applying to the cost raster based on elevation. Then step 5 takes that final base cost raster with hiking penalty or the slope penalty applied, and which is in minutes per meter at this point, we multiply it by the grid cell size to get our final cost raster output in minutes per cell. And there's that same image again showing what the final cost raster looks like. So now that we have a cost raster, we move on to the next script, which is to create service area polygons. So again, those catchment areas around facilities. So we want to define areas around those facilities that can be reached by walking, biking, or driving. And it's within a user-defined threshold. And this is something that you set when you're running the script, whether you want to work with a 30-minute travel threshold, a 60-minute, or 120-minute, or a 2-hour travel threshold. So this is what the final service area polygon looks like around a single facility, the red cross. You can see it's sort of following along those roads where we have faster travel. This is the goal of this script. So the inputs for creating service area polygons, that cost raster surface we created in the first script. And then now we need healthcare facility locations. So this will be a vector data set. And I used the locations of public healthcare facilities that are available for all of sub-Saharan Africa. And you can download it from the Humanitarian Data Exchange. This was created by Mena et al. In 2019. And it's a really great resource if you're looking at healthcare access in sub-Saharan Africa. So the process for creating these polygons using the cost raster, the script first, it's using the distance accumulation tool from ArcGIS Pro, and it sets a maximum accumulation according to that desired catchment size. And then it runs it in a loop on one facility at a time so that we have catchment areas for each facility. So here's an example of that distance accumulation output, which is a raster output. So this is a gridded data set. And those red lines around the outline of it are what become the catchment boundaries. Those are areas that have reached the maximum accumulation that you've set. Maybe you set 30-minute travel time. Once it gets to 30 minutes travel time from the facility, that's when it ends the distance accumulation. And then it converts that to a polygon. So we have a vector polygon to input into the model. So why do we run it in a loop? If you have several thousand facilities that you want to do this to, for instance, in Kenya, I think I was working with 6,000 facilities. Running it individually was a challenge. Well, this is why. So facility A here has this, I'm showing the distance accumulation output for one facility, and this is the final service area catchment area for that facility. And then in the same area, we have facility B, and this is its distance accumulation output and its final catchment area. Now, when we put those two polygons together, they are overlapping, but they are individual polygons for each facility, which is important to have that individual polygon. But if I ran it on both facilities at the same time, this is the distance accumulation output. Doesn't look a whole lot different in raster format, but here you can see we have one polygon for both facilities, which is not helpful to be used in the two-step model. So that's a no-no. And that's why I wrote it to run it in a loop on each individual facility at a time. The final step of this raster-based model is now to run the accessibility analysis. We've created the cost raster. We've built those service area polygons from the cost raster. Now we're going to use those service area polygons to run the two-step floating catchment area model. So we're using gridded population to identify where people live and the friction surface to define those catchment areas. And then we generate an accessibility raster. So again, those service area polygons are our input. Gridded population surface of your choice. WorldPop is a common one, Landscan, global human settlement layers. There are several, and I think I talk a bit about those in one of the blog posts as well. And then finally, you need healthcare facility locations, which is a vector, just a point data set. So step 1 summarizes total population within each facility polygon using the zonal statistics as table tool. So in this image, I'm showing gridded population are those blue squares. So those are places where people actually live, and each cell has a value indicating the population. And then in orange, there's a service area polygon. So the zonal statistics tool would take this polygon and summarize, sum up the populations that it overlaps with in the raster. So then that catchment area or that facility would have a population value attached to it. It then calculates provider to population ratio, PP ratio, using the calculate field tool. And this is just a little code snippet of a function I used to do that. So if you look at the bottom line, return beds divided by population. So beds is a variable in the facilities data set indicating the number of beds available at that facility. And the population is what we just calculated using zonal statistics. The next step of the analysis, we summarize PP ratio for each population point. So I guess not mentioned is the gridded population raster is converted to points where each grid cell is converted to a point. So we join those population points with their overlapping service areas using the spatial join tool. And then we sum the PP ratio values for each population from all overlapping service areas. And that's using the statistics tool. So again, if a population point has multiple service area polygons overlapping with it, we would sum the PP ratios values for each of those service areas and apply it to that population point. Step 3 is to calculate the final accessibility score for each population point. And this is also done in a loop. So accessibility is simply the sum of the PP ratios. And then we multiply by 10,000 again to make it readable because the relative meanings stay the same when you're looking at accessibility surface. And we convert those population points that which now have an accessibility value to a raster surface using the point to raster tool. So that is the entire raster-based two-step model, creating the cost raster, using that to create service area polygons, and using those to measure the accessibility. And this can all be done using freely available global gridded data sets that are a very high resolution, no dependence on census counts. So next I want to talk a little bit about how you can use modeled accessibility to validate it against reported healthcare barriers. So for one example, we have linking accessibility models with individual level survey data. So this map is showing in Kenya the performance monitoring for action, PMA, GPS clusters. So those are in dark gray on the map. And those are mapped along with modeled accessibility in yellow to red. So higher, deeper red showing higher accessibility, modeled accessibility values. So these PMA GPS clusters can be used to, that helps us understand where spatially respondents from the PMA survey, which is a global health survey, where they live within a 2-kilometer radius in urban areas or a 5-kilometer radius in rural areas. And those clusters have been displaced, those amounts, those 2 2 or 5 kilometers and even 10 kilometers in 1% of rural areas to protect the privacy of PMA respondents. So the workflow for this to link the modeled accessibility with individual level survey is to take the PMA household, which we know then what GPS cluster location they live in. We buffer the GPS cluster according to urban-rural status, so 2 or 5 kilometers. And then we extract the average accessibility value within that buffer. And so then we are able to examine, so then we know for that PMA household what their modeled accessibility score is. And we can analyze their healthcare access outcomes based on the survey questions they answered. So in this test, whether modeled accessibility predicts reported healthcare barriers, our hypothesis was higher spatial access is going to be associated with fewer reports of issues with access. So in this model, the outcome variable was from a couple of different survey questions indicating whether people had a transportation or cost barrier to accessing care. So whether they had this barrier to care because they didn't have transportation access or because it was too expensive to travel to care. And so people answered yes or no to that. And then our predictor variable is the raster-based accessibility quintile. So taken the modeled accessibility, broke it into quintiles, and ran the model on that using a weighted logistic regression and adjusting for age, education, urban-rural residents. And these are the results. So these odds ratios are comparing, again, like the low, middle, high, highest accessibility quintiles against the lowest accessibility quintile. And as you would expect, the high and highest accessibility quintiles are not associated with difficulty accessing care. So that is sort of in line with what we would expect. There is a high association with low and middle access quintiles with people reporting difficulty accessing care because of transportation or cost barriers. And this is showing those same results, but in bar chart form. So each bar is an accessibility quintile, and on the y-axis, as you go up, you're indicating higher number of respondents or percent of respondents reporting healthcare barriers. So the low and middle are the highest, and they are significantly associated with greater barriers to care. And then as you go to the right, higher and highest are not experiencing as much access troubles, and they're not reporting as much access troubles. So that's as expected. We did have a slightly unexpected result with the lowest in comparison to the other quintiles. You see the lowest is fairly, doesn't have as many respondents reporting to healthcare barriers. So that's indicating people with the lowest accessibility to care are actually not reporting that many barriers to care, which is maybe another thing to look into. Why is that? I don't know. All right, so to summarize, why is the raster-based accessibility important? So traditional models are limited by their availability for administrative units, whereas the raster-based model uses globally available gridded population. Traditional models assume uniform population distribution within those administrative units, whereas the raster-based has high resolution, 100 meter, sometimes 30 meter grid cells, which is a high resolution population distribution. Traditional models also assume travel beyond roads is not measured, whereas the raster-based allows complete coverage terrain and land cover data sets.